your host, and of course to Dr. Adul for inviting me into the meeting today. There was a very interesting talks given by all the three speakers this morning, and I think when I share my thoughts on the lessons that we learn in Malaysia, I think it will not uh, vary so much from what has been presented before, except that maybe at this time around I'll be able to tell you what we see in the country. I've just shared my slide. I hope it's coming out correctly. So, ladies and gentlemen, my name is Azlan. I am from the Social Security Organization. Uh, we are the compensation body for workplace injury and occupational disease in Malaysia. I'm not from an academic institution, and I'm also not from the Ministry of Health. Therefore, the view that I'm sharing today is our observation in terms of managing the pandemic at the workplace, and also managing pandemic as part of the diseases that we have to assist our insured persons in terms of compensation and benefits. Malaysia is um, is a country just south of Thailand, of course, and we have a population of 32 million people. And up until this month, there are about 2.67 million COVID-19 cases that has already been confirmed in the country. And out of this, there are about 30,000 deaths. So basically, almost 1 in 10 uh, of the 1 in 10 person in the population has already been infected by the virus. And I think um, everyone here in the country would have known somebody who has already been infected. And that is very important in terms of management of the disease, actually, because in terms of looking at the response of the community as well as the response of the businesses, as the number of cases increase and the number of deaths also increase, we see that the resistance to the measures that was asked to be done before slowly changes, and people start to follow the advice or the mitigation action that was asked of them. But then after a while, we also learn there are other things that happens that changes the behavior and the attitude of the population towards the mitigation actions. So these are all some of the things that I would like to touch a bit later on what is our learning points for occupational medicine in the country in terms of managing the pandemic. So when we look at the number of infection in the country, the number, I think, follows with the rest of the world, really, where there is a initial small number but shocking that initiate all the mitigation action early on in 2020, and then in Malaysia we have a sharp increase at the end of 2020. Many people were blaming it on the election that was conducted at the time, but it is more of a combination of many things, not just the local election, but also the rise of the cases and also the relaxation of some of the mitigation or the prevention measures at the time. But then we get another increase a bit later in the mid year of 2021, and then we get as high number as what it was currently. And 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 this also something that was is of interest because the numbers the actions and the attitudes really changes with more number of cases that has happened uh, throughout the 2 years that we experienced the pandemic. Um, Malaysia at the moment uh, in December is in the phase of the National Recovery Plan. Therefore, the whole country now is in phase 4 of the recovery plan. And that just means that we are now actually almost uh, in a normal situation already. Basically, all businesses are allowed to be opened. The number of people that are coming to work are now is 100%. It's no longer restricted to certain percentages of the workforce. Many social gatherings are already allowed, although the numbers are limited. That's why I say there's almost normal, but not yet normal. But this is already the last phase of the recovery plan. Despite the number of cases being reported daily, still hovers between 4,000 to 6,000 cases a day. Malaysia has gone through different phases of movement control orders, and in between the three movement control orders that we call MCO 1.0, MCO 2.0, and MCO 3.0, there are many uh, different types of control orders that exist in between, but the control orders looked into the prevention or looks into the standard operating procedures that has to be followed by the population and workplaces in terms of activity. So it looks like, for example, if you look at the graph in front of us now, even though the number of cases actually is still high compared to 1 year ago, we sort of looked at the peak and we have gone down from the peak. Therefore, the country decided that we cannot take the impact on the social and business as much as it was before, and allow for the recovery plan to 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 happen. This is also something that is in reflection to the vaccination status, because at the moment in Malaysia, we have already achieved almost 90% of all adults. But if we look into together with the children, the total population is about 80% vaccination rate. We've also started our third booster vaccine started to be given already since this month, and appointments are already given. So the vaccination plan was, I think, was conducted well, and we have achieved that number. That now in the country we have achieved, or we have reached the recovery phase 4. But the part of the recovery phase is also something that is interesting, because this is the time that we also, just like this meeting that we have today, now since activities restarted again, a lot of things are happening to relook at what have been done for the past 2 years, what could have been done better, and what could have been done for the future. So this meeting today comes at quite at the right time. We tried to do a lot of workshops and seminars before online, but with the opening of the social activities, meetings are now can be conducted face to face, and a few workshops are happening to try and fine tune the management of pandemics, especially at the workplace, so that it is we can learn from what we have seen over the past 2 years. In terms of occupational health, of course, in COVID-19, I would say in Malaysia, um, the COVID-19 increases, first of all, the optics or the visibility of public health, including public health measures. And at the same time, it also increases the awareness on health of the workers. So it is a good it is a good exposure for many of the things that we can done further, because the awareness for health of the workers, the awareness for the requirement for safety and health of the workers have increased tremendously. And this really stems from the COVID-19, because it looks at the COVID-19 as a risk of health, whether it is from the activities at work or from the conditions at the workplace. So we look at the activities at work, and now work are um, being adjusted so that distancing can be achieved, even with 100% capacity at the moment. Social distancing is still something that tried to be practiced by the employers. We know that now everybody quite used to have their temperature checked, to have their health declarations as well, to manage the disease at the workplace. And that is good, because this is when we want to talk about other diseases or other exposure to risk at work, then we can use this as part of the motivating factor for our employers and employees. We also look at the conditions at the workplace. For example, in the middle of November this year, there was a lot of, November last year, there was a lot of interactions and a lot of activities to look at the living quarters, for example, for our foreign workers. We ourselves have to send in our enforcement officers to look into the living quarters and summon the employer to better the living quarters of the foreign workers in the country. So that is something really fantastic, coming from heightened awareness on the health of the workers. We also look at ventilation. A lot of people talk about ventilation these days, improving the ventilation, trying to get an indoor air quality measurement now. You need to have a queue to wait for when your turn can be done. In fact, ventilation in the workplace is something that also been looked at as part of the code of practice for management of infectious disease in the country, as well as sanitization. So a lot of sanitization is happening at the workplace. I would like to touch on this a little bit in some of the things that we think should be thought of in occupational medicine. But basically, occupational health has had a heightened awareness. Um, this due to the COVID-19. I think this is happening all over the world. Now people seek the doctors or occupational specialists, or a lot of people who are not occupational health based are able to talk about this requirement of health at the workplace. In terms of what we can learn, there are plenty of things to be learned and plenty of things to be discussed. And as was presented by Professor David Koh just now, which is very interesting, I would like to touch into five uh, area or five uh, thought pointers, what I would like to call, into look into things that I think could have been improved, and things that could have been learned or maybe not anticipated before the pandemic, but now we have to anticipate in the pandemic. I'm going to discuss a little bit on the whether where awareness translate into attitude and practice. I'm going to also discuss the boundary between occupational disease and community acquired disease, which is important for my organization. Um, we're also going to look at requirement and adherence to preventive measures, what are being proposed by our specialists, our occupational health and public health specialists, and one can actually be conducted at the ground level, which is very important because you must have that synchronization. I'm also going to look into addressing new risks, not the virus, but things that come up uh, later with the activity that we do, and also managing infectious disease risks at the workplace as something that we might want to learn from, coming from what our experience is. So I'm going to start now uh, with the first issue, um, awareness, attitude, and practice. So I'm going to use healthcare worker as a very uh, important example on this, because it is very well studied that healthcare workers are exposed to the pandemic. It is also very well studied because of this exposure that the healthcare workers needed all the precautions that are afforded to them and to be prioritized. In the beginning of the pandemic, for example, when the uh, PPEs are in short supply, the priority of supplying PPEs are to the healthcare workers. Even in our organization, where people have to come to work, um, we buy our PPEs, but we also donate it to the healthcare workers because of the short supply. So um, the healthcare workers are exposed, but they are also the first that are given knowledge about the disease. They are they they are the ones who are given the all the information early about the manner of the disease, and how the disease spread, and how to prevent the infectious disease. Of course, healthcare workers are the ones that suffers the most, or that was under the most burden of work, and everybody was truly grateful to the sacrifice made by the healthcare workers. I myself has got many friends who are affected by the work that they need to do. In fact, many of healthcare workers in the beginning work uh, for a month straight without going home because they were worried at the time of spreading the infection to their family members. Therefore, they actually stayed in the hospital. So the healthcare workers actually has got the most uh, knowledge about the disease. They have the most experience with the disease as well, and also they have the most experience, or the priority in terms of protecting themselves against the disease. In July this year, we then were reported by our own Ministry of Health about nearly 10,000, 9,700 actually, healthcare workers were infected by COVID-19. So that's quite a big number. However, surprisingly, we also were told that actually most infections occurs not through their task as a frontliner, not from their exposure at the workplace or from the patient, but most infections actually occur due to other personal or social engagement. This even happened at the beginning of the pandemic, and still happen later phase of the pandemic. Stories went around and we were quite puzzled at the time. For example, there were an occasion where 48 healthcare workers were infected by COVID-19 because they attended the wedding of another healthcare workers. So the questions that are raised is that how could this happen? Healthcare workers, they are most ideal candidate in the field of occupational medicine to impart the knowledge and change behavior of others. They witness the complication of the disease. They are well informed and they are well trained of the characteristics of the disease, but somehow in their other activities outside their workplace, they let their guard down and become infected. So, what could be the reason of this? In the future, when we think about occupational medicine and looking into imparting knowledge and behavior, then we might want to realize that, even with all the knowledge, it might not still work. We don't know why this is happening. Is it because they're not understanding about the disease? Maybe, but they cannot be. Is it simple pandemic fatigue? They're too tired, or they're too they needed to let go and be in their social circle. It happens in the beginning of the pandemic. It still happened towards the tail end, or what at the current moment. So this kind of questions of learning, I don't have the answer for, but this is going to pose a challenge in occupational health education and behavior change towards a health risk at the workplace, because this gives us a shock on what happens when even the most people who got the knowledge still get infected, and they got infected outside their premise of work. On the other hand, we also know that the frontliners in the beginning, of course, healthcare workers are known as the frontliners. However, with the movement control orders, a lot of other enforcement officers have to come into line. Therefore, the role of enforcement officers, especially, they are recognized as frontliners. They have to deal with the population. For example, in the picture here, they actually have to stop every single motorist to check whether they are the ones who are allowed to be out working, or whether they are not allowed to be out working. So there's a lot of risk of exposure to the population. Police, especially, they play a very big role in maintaining social order. They're outside facing the crowd, dispersing crowd, maintaining access and exits, maintaining the borders of the state when we have many different uh, types of control orders. Um, but this is done with basic mitigation preparation. They of course they've been told on, they've been educated on how the infection is spread, and they're given PPEs, which is a very basic PPE involving the mask, and as well as sometimes they wear their own gloves. um, the frontliners also faces a lot of other risks at the workplace doing this duty. So they face physical risks, such as in this case here, storm and heavy weather. They also face emotional risk because they are also uh, having stress out with the exposure, and then having to go back to their family, and other pandemic risks. But on the other hand, with the number of uh, police officers outside, with the knowledge that is given, again, we see the same issues. More than 10,000 police officers were reported infected with COVID-19, and this double with their family members for another 10,000, so about 20,000 uh, uh, officers or and their family members were infected by the COVID-19 in the country. Despite that, um, their interactions with the communities, but this also happened while performing their duties. So there was there were gaps that we see, that in terms of what they do as a frontliner, did we not help them to protect themselves enough, that the number of infections are high. So the numbers of infections high in the frontliners, uh, in terms of the enforcement frontliners, but it's also high in terms of the healthcare frontliners, for two different reasons. One is in social events, the other one is in actual duty that they perform. So this becomes something that we wanted to look at. So does awareness translate into attitude and practices? In such a short moment in time, the cases in Malaysia for healthcare workers, this creates a requirement for the future when we look into education and behavior, when we want to mitigate health risks. The expectation that by having enough knowledge and enough awareness might not be enough. It needs to be supported by resources, for example, in case of frontliners, and also systems for prevention tools, for example, the PPEs, but also needed to be supported uh, in terms of continuous motivation for the workers to continue to do what they do at the workplace, and when they are not at the workplace. So it looks like there's not enough time for the behavior to change, despite we think that the behavior should have changed. So it poses a challenge later if we deal with another disease, or whether we're still going to continue to have to deal with this COVID-19 in 2022. The next bit that I wanted to discuss is about occupational disease or community acquired disease. Now, this is important for us in the compensation area. Um, in Malaysia, we also get reported how many of the infections are due to clusters which are linked to the workplaces. So, for example, here, um, almost almost around 600,000 infections was due to the uh, infections risk exposure at the workplace. When we look at the clusters, group of infections, we will see that although there are community clusters, which are clusters that exist due to the residential area, we also see there's a high number of clusters that started from the factory or industry, construction sites. So these are workplaces. Now, the question that is raised was that, look, they are getting the disease, and these are the people with positive COVID-19 from their exposure at the workplace. Now, this might not be an issue with countries where social security setup have been adequately addressed the issue of COVID-19 as an occupational disease, but it is still something that is raised in Malaysia. If it is due to interactions with other co-workers at the workplace, does it fall into the occupational disease category? When this question was raised early in April 2020, we in Malaysia at the time was quite clear, because coronavirus, although it was associated with SARS at the time, but coronavirus is something that already listed as an compensable disease. So if somebody, a person obtained or was infected because of their job, especially as a healthcare worker, therefore it is considered an occupational disease and compensable. The question that comes out, however, is many of these hundreds and thousands of infection are not among healthcare workers. So it is not because their job increased their risk of infection, but it is because their their exposure at the workplace gives them the risk of infection. So we look into this, and this becomes an issue, because when a person is exposed at the workplace, due to exposure to their colleagues at the workplace, they actually have to be quarantined. And what happened if, because of the quarantine, despite not having symptoms, their earnings or their wages are being cut? Or what happened if business cannot be run because of this quarantine? So it becomes not only academically a diagnostic issue, but it also becomes a social issue. In So that was this was used in early 2020, but in February 2021, the country decided that the COVID-19 that is due to exposure at the workplace has to be dealt with as part of an occupational origin disease. Therefore, the Social Security Organization then decided that we shall then give assistance similar to an occupational disease due to healthcare workers. So anybody, all workers who gets infected because of exposure at the workplace becomes eligible for the social benefits under the occupational disease and also under employment injury. So that means they are eligible for temporary disablement benefit. If they end up with a permanent disablement, they will be able to be compensable as well, medical benefit as well as rehabilitation benefit. So is there a real uh, line whether COVID-19 is an occupational disease, or do we just consider that as community acquired disease? Once we move to say that COVID-19 coming from the workplace clusters are an occupational disease, then the question is raised, what about other disease? Do we then consider tuberculosis, for example? Do we need to consider influenza, for example? Or if you are infected with malaria or dengue because of the mosquitoes at the workplace, do we then consider that also as an employment injury that is compensable under the social security system? So these kind of questions are not surface yet, but it will surface later as part of the discussion in the occupational medicine field. Um, we are going to have to deal with that later once the pandemic is subsided. But these are some of the things that we are learning from our decisions made during this pandemic. The third points that I would like to also discuss from our learning is the requirement and adherence to preventive measures at the workplace. So in occupational medicine, the procedure for medical removal and protection is used when a person is exposed to a certain level of hazard. For example, if we measure a chemical which is high at the workplace, then we can remove a person from that workplace. Now, in COVID-19, similar approach is used in the country when there is a cluster of infection in the workplace. Then companies, or when there is an infection in the workplace, then companies will start to use the stepwise measures to contain the infection. So the index case is isolated, and then the close contacts are then going to be identified, and then isolation of the close contacts, and then they monitor the close contacts, and when there is enough time given, at the moment Malaysia is 10 days, and there is no symptoms or no positive case, they can come back to work uh, with the return to work procedures. But it becomes different when there is a cluster of disease at the workplace. So the stepwise measures that was mentioned earlier now includes, for example, if the close contacts are too many because there are too many positive cases. Now we are going to talk about closure of the office or closure of the factory or the workplace. It can be from the organization themselves in our country, and a directive can be given by the authority. I'm sharing here the directive to close an office, and also a directive to do sanitization, to clean the office as well. So this comes into play when there is a cluster of cases. And then after all this is done, measures are taken to reopen the workplaces. The only question that we to raise now is, well, can this be followed through by the workplaces? Because there are also other mitigation actions that are being taken. Uh, Workplaces are providing hand sanitizers, they're providing face masks for all their workers, temperature checks. Some are installing air purifier, and also questions about swabbing. At the moment, swabbing is no longer compulsory, but there are organizations that are doing weekly swab, 2 weekly swab. So are all these proven, or are these something that can be used at the workplace? Um, many companies are claiming their types of air purifier are the best. Some are claiming their types of sanitizers are working. In the beginning of the pandemic, public health specialist says you need to sanitize the workplace. Um, Now public health specialists are saying sanitization doesn't work. Might as well spend the money somewhere else. Do you swab your workers once a week, or do you swab twice every 2 weeks? Or do you swab them daily? Or do you only swab them when they have symptoms? So these are all not yet uh, given the actual what is required. And the occupational medicine community, however, also have not come out strongly to provide a guide on the matter. So this question of what are the preventive measures at the workplace that really work, that can practically be done, is not yet addressed well, despite we are already 2 years into the pandemic. Um, Point number four, I also would like to look into a new risk, and of course, work from home order. Um, it can be coming from the organization. It also comes from the government. This one is a poster from the government. So everybody has to work from home. And like what was mentioned by Prof. David just now, we try to cope when we work from home. So there are many ways. Um, some people take Tai Chi, some people do a lot of other things. I choose to work in my garage instead of working in my room at home. So many different ways of how people try to cope with working at home. Of course, we discuss a lot of discussion about virus as a new risk, but I think everybody knows that the mental health part is also an issue that needed to be required to be discussed and needed to be looked at. So mental health is a heightened risk. It's not a new risk, but now it increases. We are getting more reports everywhere about cases relating to mental health, domestic violence, depression, um, or stress um, happening with the work from home. Um, in determining the process for remote and work from home, most companies would have addressed the requirement for productivity and physical support, whether internet, computers, document transfers, etc. The big ones, the one with resources, might also look into the issue of mental resilience, but these are not always specifically addressed. So you might have a helpline at your workplace in case people cannot access the internet, or if people cannot access documents, but not necessarily people will have a helpline when people are stressed or needed to talk about their work in terms of mental health. Um, a little bit later, people start to realize that working at home sounds good, but may not be necessarily as good as working at the workplace with all the distractions that happens. So when addressing this risk, this is also something that needs to be comprehensively included when we move into going to work in a different new norm. For example, here in Malaysia, uh, the mental health support comes in many different ways. Um, we have a national mental health call center that people can call, but there are also call centers that are provided by NGOs, by local governments, by other organizations. What we think should be even better if the practice of occupational medicine, when looking into working from home or sending people to work remotely, that the companies then also look into whether the mental health consultation, mental resilience part should be addressed together, not only just about the productivity and the tools to be able to enable a person to work at home. We need to look into this part as well. Um, and that brings us back to my last thought points, and this is managing infectious disease risk at the workplace. So the last points that I would like to address from our experience in managing COVID-19 is how to continue managing infectious disease at the workplace now that we have learned so much about what actually happened when the pandemic do come. Most of our business continuity plan have been relying on the development based on business continuity plan for influenza. So we are not totally unprepared, as what was mentioned by Prof. David. Um, Although there are plans developed for this, COVID-19 showed us what happened in reality and the challenges. Many would have said that we have done enough, but we can probably prepare better. At the national level in Malaysia, we leave it to the National Security Council. But at the organizational level, I think the role of occupational health specialists, the role of occupational health doctors could become very important. So there are a lot of discussions about managing this that is still happening. What I'm showing on the slide, for example, we are still having webinars and seminars on how to manage the spread of COVID-19 at the workplace. 2 years after the pandemic starts, we are still discussing, we are still debating on what are the best ways to do it. Um, we know that there are many resources that people use in managing um, workplace infectious disease. We look at, for example, use of the business continuity plan that was developed for influenza and SARS by different companies, a lot of reliance to the directive of the government during specific phases of the infections. When looking at ventilation and reduction of infection within the workplace, we look at various code of practices, including the indoor air quality. We look at guidelines produced by the Ministry of Health, the Department of Safety and Health, even guidelines from the Social Security Organization, and many other guidelines that comes from many other different organizations. And this is something that we need to improve in the country. We need to develop a specific, comprehensive, and updated guideline on managing pandemic. And still happening. In fact, at the moment now, as of now, there's a group of occupational medicine specialists which is now having a workshop with the support of other agencies and disciplines to develop a new guideline on managing infectious disease at the workplace. We need to learn that we need to address all the points that was raised before this and combine this with new knowledge, new incoming knowledge as well to guide for a more practical guide for industries. For example, I think we did not consider deeply on the when developing practice guidelines on the social and economic disruption that may occur even to a small company. It makes a big difference, for example, when if we recommend to close the workplace to mitigate the infections, it makes a big difference if we say 3 days compared to 7 days compared to 14 days, like when we begin earlier. So these kind of things needed to be considered practically as well as practically that can be practiced by the industry as well as enough and adequate to prevent infection. So I hope my colleagues who are now working on the workshop, I'm supposed to be there, but I'm here in the conference today. Um, we'll be able together to come up with such guideline after all these learnings that we have in managing this for 2 years. In fact, one question that often was raised, for example, is about vaccination. So this was brought up. For example, when you want to reduce the risk of noise-induced hearing loss, it is mandatory at the workplace to wear the earplugs. Or if you want to remove or reduce the risk of injury of falling objects, then we mandate that the workers must wear a safety hat or safety shoe. But to reduce the risk of infection of COVID-19, why can't we make it mandatory for vaccination against COVID-19 for the workers? Here in Malaysia, we still face a dilemma between disease control and the rights of the human rights, between the health of the workers, cost to the business, and the right of the person. Until now, the stand of the government is that this is not mandatory. It is still a, done voluntarily to be vaccinated. But to do many things in the community, even you must show proof of vaccination. So in the end, it looks like almost compulsory, but it is not compulsory. So we're not sure what is the line there. You don't have to do it, but if you do not vaccinate yourself, you are not able to do many things. Employers, for example, have right to insist the staff to be vaccinated against the COVID-19 according to the safety and health law, but it is not compulsory under the for the whole country. It is compulsory for federal civil servants to be vaccinated, otherwise actions can be taken. So these questions are still being weighed and still being decided. So when we look at the managing of infectious disease risk at the workplace, we are learning all this, and pandemic give us a really good experience on what is happening with the decision that we keep on giving and with the idea that we keep on putting as occupational medicine specialists, whether it can work or whether it can be followed by the people who are supposed to follow it. So here we go. What if we can say it is mandatory for the vaccine, for example? Will this be applied for influenza, hepatitis, meningitis, or will not be applied? So it is not purely just about the managing of the disease. Now it is also about managing the disease together with the economic impact, together with the social disruption. So we have to consider all that as occupational medicine specialists when we wanted to put in a guide on how do you manage infectious disease risk at the workplace. There are also other things, ladies and gentlemen, apart from the five things that I just listed here. This was mentioned briefly just now. For example, what happened with long COVID. Long COVID is there, but it is not very well established in Malaysia yet. What are the uh, effect of long COVID? How do you diagnose it? How do you separate the the complaints of long COVID, whether it is due to COVID or whether it is not due to COVID? How then will this be considered in terms of social security? Whether compensation can be calculated on this, whether disability and whether if long COVID will affect employment or vice versa. So this also comes together with effect of vaccination. For example, the Malaysia has not yet reported adverse effect of vaccines. There are many side effects that was reported, but not yet death from vaccines. But what if that happened? How then we treat them as part of the occupational medicine, occupational health practice? So I'm right at the end of my presentation. Today, there are a few thought points that I think lessons that we learned in terms of occupational medicine from the COVID-19 pandemic in Malaysia, specifically the, the actual uh, practices and actual behavior does not necessarily come from the awareness of the disease as well as the practices at work. We also look at the boundary of between occupational disease and community acquired disease when it becomes one or the other. We also look at the new risks such as mental health, and we also look at whether the managing infectious disease risks at the workplace can be something that we adhere to by the employer as well as the employee. So these lessons that we learn together with many other aspects in managing the disease that we have been experiencing in the past 2 years, plus all the academic papers that are produced and published by the in terms of managing this, can be something that we use at a national level, organizational level, at a professional level for occupational medicine specialists, as well as at the working and the company level. So those things are a lot that we are learning, a lot are being discussed, and 2 years, almost 2 years, for since the start of the pandemic, we are discussing this, and now it's a good time because we are resetting everything as supposed, and hopefully we do not get a return of the peak, although a lot of being discussed about the Omicron variant. But if ever we get a return, we should be better prepared from what we are over the last 12 months at least. So ladies and gentlemen, that is my last slide. Thank you to the organizer, and I hand back to our chairperson.
sorry, I have a question for Dr. Azlan. Yeah, did Malaysia, the factory have to close for COVID? How many factory in Malaysia?
Um, Dr. Adul,
Yeah.
if there is a cluster, if there is a cluster of cases, then the authority, the Ministry of Health, will order for a closure of that factory or that workplace. The number of days depends on the number of cases as well as what activities are being conducted by the workplace. I can tell you, in fact, our officers, SOCSO officers, when we have cases, we are also being ordered to close. Um, and we are only allowed to reopen when all the workers has been screened and the office has been sanitized. So this also happened in all the other workplaces, except that now when the tests are easily available, people then can do it for themselves. So the companies might want to think about closing or partial closing or just closing a department to contain the infection. And this is where the questions raised. How many days do you close? How big, how far do you close? Who are the people that you say don't have to come to work? And when you say you don't come to work, that means services cannot run. Therefore, the company become closed anywhere. So these kind of questions are the one that we need to develop a clear guideline on how to do it.
Okay. And for the workers, if they have COVID-19, uh, so they all compensated.
Okay. In the beginning, in the first year, all COVID-19 cases are sent to a quarantine center. If the person has got symptoms, then they will send to hospital. If they're not symptomatic, then they will send to a quarantine center. But since June this year, we have also allowed for COVID-19 cases to self-quarantine at home. So if you found yourself positive and you have a good place, a good home to stay in, enough resources, you can actually be quarantined at home. During the peak of the infection in May this year, the number of cases are so high that our quarantine center cannot cope. Therefore, we open up many private quarantine centers as well. These are hotels that people can go in to be quarantined also. So to answer your question, Dr. Adu, in the beginning, all are separated and quarantined, which really works very well for the first year. But in the second year, in 2021, when the number of cases are very high, even now, people are allowed either to be quarantined at government quarantine center, or they can quarantine themselves at home.
Okay, and if the worker got COVID-19, you think that they will all compensated by proposal?
Yes, since February this year, we have approved a directive that if they get COVID-19, they can be compensated. There are three types of compensation is available. The first one is when they are positive and they're quarantined. Therefore, for all the days that they are quarantined, we shall pay for their salary. And then if ever they end up with a permanent disability or death because of the COVID-19, they will also be compensated as well. And if they needed treatment or rehabilitation because of the disease, then the medical treatment can also be paid for by Perkeso.
Okay, it's just like in Thailand,
Yeah.
all workers with COVID-19 can compensate by Social Security
Mm.
Office. Yes,
Oh,
I
okay.
think there is many factors. I think there is also academic and also a political factor. Also, because the economic is not good, Yes, and the people are not feel not so well with the government.
Yeah,
Yeah,
I agree, Dr. Adul, because in the beginning, the argument is about whether is this occupational disease or this is not
yes,
occupational disease.
yes,
But when the social and economic factor comes in, then it's no longer a purely the disease origin. It's also about the social support that comes in. And that's when we came to a decision that it doesn't matter whether you're a healthcare worker or you're not healthcare worker, you got a COVID-19, from the cluster at the workplace, you are eligible for compensation.
okay. Thank you very much.
Thank you, Dr.
Professor Wilawan, do you have any question? Open the speaker, please. Professor Wilawan, okay.
Yeah. Uh, just today that one of my colleagues lied to me that she got so much test for the COVID-19 until she have a lot of complaint. Can they stop that? What do you think about it?
Um,
Not vaccine test for the consequence day.
I think at the moment, Dr. Wilawan, the test really serve to give assurance. That's all. Because we all know that the test only give you result at the moment. It's like a snapshot of a camera. It is not. It doesn't say that tomorrow you're going to be negative. You're negative today. You're not negative tomorrow, or you're not going to be negative the next day. But but it gives a lot of assurance to the workplaces, to the employers, as well as your colleagues to know that you are negative. So if you're negative, you don't have symptoms, we like you to be with us, basically something like that. How often do you have to do the test is something that I really cannot answer. In the beginning, when we opened the industries, there were directives that everybody must be tested every 2 weeks. Uh, but that lasted only 1 month, and then it is no longer applicable. There are certain industry that are doing it now for assurance. I can tell you, for example, our construction industry are testing their workers every 2 weeks diligently, and we understand that because not only they are practicing the preventive action very strictly, they also want their people to be free of the disease, because if they have a cluster, they close down, they lose a lot of their business when they cannot operate their construction industry. So they do it very strictly. But there are other companies who are not doing it because they don't think it's worth to be doing it anyway, maybe because their exposure is not the same. So yeah, this balance is what we are uh, I think the challenge is to understand that balance, and also to convince people when things are not scientifically, um, you know, not scientifically sound to do, to have your screening every day. Like I said earlier, it is not something that actually tells you you're going to be negative for the next days, but people want to do it, or people make their worker to do it because it gives assurance. That's all. So how then occupational medicine specialists educate people? Look, it's okay if you don't do it, but you must maintain your social distance and wear your protective mask, for example. That is more important. Um, that is the biggest. I think for occupational health specialists, our biggest challenge is to re-educate the population. Um, I don't know how to do it. Maybe Yeah. I'll give you an example about sanitization. Every company now will bring some other company to come and clean their office. We don't know what chemical they use. We don't know whether it's really going to kill the virus. It kills the virus today, but tomorrow somebody will cough on the table and you're still going to have that virus on the table. So it doesn't really work. But everybody is doing it, because if you don't do it, your workers will not come back to work. So how then we re-educate people to say, look, you know, that is not the main way to prevent the disease. But yeah.
Good.
Thank you very much, Dr. Azlan.
Thank you,
Thank
Dr.
you for accept our invitation, and because you are very close neighbor, and we contact to each other last year. You came to Thailand almost every year by
Yes.
our invitation.
Thank you for the invitation, Dr.
Yes, maybe if next time we have a chance, I will invite you again to come to Thailand and see face to face. Okay.
Thank you.
Thank you very much.